Okay, so good afternoon and welcome to today's forum hosted by Georgia Chapter of HFMA. I'm Lil Klug with FAM 360 and I am the Georgia HFMA Forum co-chair. Before we get started, I would like to review just a few housekeeping items. All phones will be on mute to avoid interruptions during the broadcast. Please submit your questions via the question box at any time. The speaker will provide the answers at the end of the presentation. You'll find a link to download the presentation in the chat box. This link will take you to the Georgia HFMA website under the tab in case you missed it. We'll also post a recording of today's session in that location. Everyone on today's call is eligible to receive continuing education credits for participating. Be on the lookout for this form in your email. You'll be able to use the form to self-submit for your credit on the HFMA website under the Membership Info tab. Now, it's my pleasure to introduce Kirby, who is very generous with his time. He's always willing to help the Georgia chapter with his information. He's a wealth of knowledge, and I welcome him today. Kirby is the Senior Vice President of Solution Strategies at Argos Health. He has been with the company since 2009. During this time, he has helped direct the operational effectiveness of the company and has been instrumental in business development, training, and client relations. Prior to joining Argos, Kirby led 5-star resort service terms at the Sea Island Company. That sounds like fun, Kirby. Why'd you leave that? Kirby and his wife successfully purchased the document destruction company and estate. Kirby and his wife successfully repeating myself here. Kirby holds a Bachelor of Business Administration from Terry College of Business at the University of Georgia with a focus on management. And with that, I turn it over to Kirby. You're in good hands.
Thanks, Lil. And before I get started, just a really big shout out to Georgia HFMA for all their efforts of trying to keep the educational and the quote unquote meetings going throughout what we're all facing. I see we've got quite a few people that have logged in to listen to the session. So thank you for their time and thanks for participating in what Georgia HFMA is trying to get out there. Lil, great work on y'all's part. It's not easy when we're all in different spots trying to make these things line up. So if there are a few technical difficulties, please forgive us. And I want to reiterate, thank you to the participants for giving us their time today. We're going to talk about what I guess could be the proverbial fly on the elephant's rear end, but everybody seems to want to talk about it, and that's some VA claims. I hope today you'll find that there's some information that you're getting that you didn't previously know. Maybe it offers a little clarity. And along the way, please, like Lil said, use that Q&A section that you should see on your screen where you could type out some things to ask. I'm going to do my best to answer every single one of those at the end. If it gets a little too specific, we'll probably just say, hey, let's circle back offline because we might be dealing with something that's specific to your particular location and not necessarily a global answer, but I'll do my best to answer them at the end of this session. So without further ado, let's get started, everybody. I'm not going to take too much of your time today. And if you've ever listened to me in a face-to-face in-person session or a webinar that I've helped with in the past, you have probably seen this slide. And you've also heard the story I'm about to tell. But back in 2010, I believe it was, we did our first presentation for a Georgia HFMA Institute down in Savannah, Georgia. And when we were getting going on putting that slide deck together, we came across this Gary Larson Far Side ad, and we put it in play. And, you know, like any good pitcher or quarterback or receiver, once we put it in play, we've never really taken it out of play because it is relative today and seems to make a lot of sense for what all of us go through, either on the provider side or the vendor side with regards to revenue cycle. It seems like these doors are the ones we get to walk in or out of every single day. Just to get us started, I'm going to give you a tiny bit of background on Argos Health, and I'm not going to make it too salesy. I will rush through this, I promise. We're a complex claims company. We focus on 4 specific claim types. You see them laid out before you: work comp, MVA/TPL, out-of-state Medicaid, and then the last one that we're going to talk about today, VA claims. For 2 years in a row, Black Book has given us the #1 ranking for their as a complex claims vendor. We're excited about that, and to us it means a lot because Black Book isn't one of those companies that you can pay to be a part of. So this is, to us, it's completely anonymous who all they're reaching out to. We don't know when the surveys are taking place. We just all of a sudden got the results, and we're really happy that out of all 18 categories, we placed #1 in 9 of them. One last little detail piece about our company: 4 offices, as you'll see before you, well over $1 billion collected. I think right now, maybe really even close to 1.5 billion, about 250 hospital clients, over 150 FTEs. And as we stated a couple of slides back, we work on 4 types of claims, which we will fully acknowledge are not a large part of the revenue cycle. However, they seem to make up most of the headache that you deal with every day. So if everybody will just humor me for a second, I'm going to ask a question on the next slide. And when I ask it, I would absolutely love it. I won't even see this as they come in real time. But if you could take a second to make sure your Q&A part of your webinar software is working, if you'll just type out an answer to this next question, it would help a lot. So here we go. Really simple question for all the providers that are listening. Would you call the VA health insurance? And I'm going to take a really awkward 15-second pause, and I'm not going to say a thing while we wait for some folks to type their answer in. Please go ahead and do that. "11, 12, 13, 14, 15. 15 seconds seems like forever when you actually take a second and don't say a word. Looks like we did get some answers to come in. I can't see those answers, but I can see that we had some participation. So again, would you call the VA health insurance? My answer to that is no, you shouldn't. And then you're going to have to start and say, well, okay, I get that, but tell me why. So I thought I'd lay out a few reasons why I think you shouldn't call it health insurance. So just a few things to start off right away. Do you have a contract with the VA? Do you have one with Triwest? Do you have one with Optum? Well, that last one, the Optum piece, maybe you could answer now you do, because what we're going to talk about as we get into the bulk of the presentation and what's been going on in 2020, I'm assuming almost every single provider that's listening into the webinar has heard something from UHC or Optum and has asked if you want to be part of the CCN. So now you might actually be a little bit closer to having something that could be considered health insurance because you've got a contract in play. But when you start talking about whether the VA is health insurance, ask yourself, what are your timely payment penalties with the VA? Again, I would assume if you're a provider on the webinar, if you've got a typical Blue Cross Blue Shield claim and you've got claim acknowledgement and you've provided them with whatever they need in order to process the claim, if they don't pay in a certain amount of time, you get to actually impose some penalties on them. Let me know if anybody out there's got that option with the VA. That would be something new to me and something that's never been, that's happened before in this space. The third bullet point, can you name your veterans policy number and group number at time of registration? If we went back before June 6, 2019, you would pretty much get a resounding, there's absolutely no way. And that would be a nationwide answer. But hopefully since things have changed over the course of time since the Mission Act went into effect, you are slowly starting to see a trickling in of health insurance, I shouldn't even say health insurance, VA cards that look more like your typical health insurance cards, like the one I carry in my wallet every day.
Hey, Kirby.
Yes, ma'am.
I did a quick poll here and we had 13 people say no, and we had 7 that said yes.
Awesome. So a good mix. And what's really interesting, thanks for that, Lil, that's great to know real time. As you can see, as we're going through just these 4 bullet points, just a flat no answer is harder and harder to say that's the way it should go. And an absolute yes answer certainly doesn't present itself very well, because there are plenty of reasons why it couldn't or shouldn't be quote unquote health insurance. So that's a great mix. And the good news is nobody's wrong today. Last bullet point, when you're thinking about the VA, what data have you loaded into any sort of contract matrix, charge master, clearinghouse, et cetera, where you could accurately predict what your reimbursements would be based off of what claims you have going out? Are you modeling it against anything? A little tip, if you wanted to, you'd be safe in modeling it after Medicare rates. However, there are some, little caveats to that, such as they're only going to pay up to a certain percent of Medicare rates for unauthorized care. There's just little things that'll maybe, when that payment comes in, you'll think, well, that's not quite Medicare. But then again, they don't say that it will be absolutely Medicare rates. But if you wanted to go ahead and load that, what a great thing to do. We've gone to work for plenty of hospitals where they had nothing in there to base their charge to reimbursement off of. And we advised them, well, let's just go ahead and get that loaded as a Medicare payer. So at least that way, if you're going to bill $1 million in claims this year to the VA, to a VA EDI transmission, then you could expect some sort of reimbursement so you can start to operate your business better. All right, so again, if it's not health insurance, I thought it would be very helpful just to give you an exact quote from a handout I received in person a few years back of what the VA calls itself. And I don't need to read the quote. You can read that just as well as I can read it to you. But you can see what the VA says is they are purchasing Medicare within the community for their participants. Well, that's a lot different than what you would call health insurance, where a company is collecting premiums in order to provide a benefit. Now, you'll notice on there's a parentheses and it says CBOX. So also know that the VA operates these community-based outpatient clinics, and then some they just call OCs for outpatient clinics. I took the first 9 lines of where those are available in Georgia. If you wanted to go to the website va.gov and search for CBOX or type in community-based outpatient clinics, it might be helpful to you in the community where you operate to know where one of those exists, because it could help your front end team know where they could help those veterans seek the care within the community that's not necessarily at your facility. If they needed to go to a government run facility, but there's not necessarily a true blue VA close by. So take that away and see if you need to look that up and give it to your patient reg team, front end, patient access, et cetera. So we've talked about some reasons why you shouldn't call the VA health insurance. Before we get to the Mission Act, I thought it would be helpful to talk about what sometimes gets confused with VA coverage. So I've got 2 definitions that I wanted to bring up, because typically when I talk to someone at a hospital about VA claims, they usually ask the question, well, what about Tricare? And there is confusion in the marketplace now, because you have Tricare, as you see listed out before you on this screen, and it's defining what Tricare is, which basically you could describe as coverage for active duty military. Within Tricare, you have Tricare East and West, kind of a left and right side of the country. And then, as you're going to see in a little bit, you also have Triwest. You cannot confuse those. Tricare is its own thing. It's its own payer. It gets its own billing. It has its own coverage restrictions. So Tricare bubbles up to the top when discussing VA claims, but Tricare is different than your typical VA coverage and then your typical VA coverage through the community care network. It's its own payer source. In addition to Tricare, you've got ChampVA. ChampVA is its entirely separate payer class. And you can read just as well as I can, but ChampVA could be described as the coverage that's available to family members. And it's either when someone is totally disabled because of something that happened within their time in the military, or they died. So our government offers coverage to those family members of those service members. ChampVA within your, let's just call it your billing system, it needs its own payer class 2. It goes out on its own EDI transmission that's separate than Tricare, that's separate than traditional VA, that's separate than Triwest, that's separate than Optum. So right away, I mean, we've barely even scratched the surface of what is this VA claim and what's going on in 2020. And you can see I just talked about you potentially could be sending, especially in the region we live in, 5 electronic transmissions for what I will put air quotes around and say are military claims. Very important for the front end reg staff to ask some questions and try to figure out exactly what coverage are we dealing with here. Because once those claims go out the door and they're potentially pointed in the wrong direction, it makes the payment of the claim monumentally more difficult. And everybody on the webinar from a payer or from a provider side realizes that, just like if you were to point a Blue Cross Blue Shield claim to the wrong in the wrong direction, or if you send a Medicare claim out to traditional Medicare instead of one of the Medicare Advantage claims, you know, that just compounds how long it takes for the claims to actually pay. So if we were to take away one thing right now, write down to take back to our business office team or our patient access team, I would say write down, we need to make sure we're bulletproof on the front end of knowing exactly what type of coverage the person presenting to us has with regards to military claims. All right, now in the VA space, let's go over a couple of terms that are common in the VA space, but they don't rear their head in any other payer class. The first one that I thought was really important is to discuss what exactly is the Millennium Act. And if you're actually a biller in a business office, what you sometimes hear that means Millennium Act is a denial reason for pending mill bill ruling. And all pending mill bill ruling is basically telling you is that the VA is taking a second to see if they should enact what the Millennium Act allowed and should they pay the claim. So that's what Millennium Act means, and that's what pending mill bill ruling means. You can read the definition, but it's a way for the VA to pay for emergency treatment for non-service connected issues. So let's just say a service member, loses their right arm while they're in active duty, but they go to the ER for, a broken ankle. That's not necessarily service connected, and the VA allows for the Millennium Act to come into play in order to pay for that treatment. Now, the last little dash mark on that slide, extremely important, especially the notification part, and we're going to talk about that in just a little bit. When that veteran comes in, to have your absolute best chance at having that claim paid, because remember, it's not service connected, so it's not necessarily something that the veteran was supposed to go to the provider for emergent treatment. But if you notify them within 72 hours, you've got a really good chance of getting that bill paid. It's going to require some more legwork, such as I hope you have your EDI transmission set up. Not having it is not the end all be all, but it certainly helps. And you're going to have to send in a UB04, and you're going to have to send in MedRex, and you're probably going to have to send in MedRex again and maybe one more time. Little side note, there was a study done by an independent consulting firm of what's going on with all these MedRecs once they go to the VA. That firm found that the VA had 5.5 miles of medical records backlogged waiting to be attached to claims. Now, if you take at your desk or at your home office, wherever you're sitting now, and you take an 8.5 by 11 piece of paper and you stand it end on end, that's what you call paper thin, right? Well, what if you had 5.5 miles of records stacked like that were waiting to get assigned to a claim? Now you might start to see why some of these claims are taking a long time to pay, because of just the sheer volume of paper that needed to be attached to a claim in order to verify, okay, should the veteran have sought treatment? Was the treatment justified? Were steps taken that were appropriate, et cetera, et cetera. So I went off on a little bit of a tangent there on the Millennium Act, but if you came to this call and you thought, you know what, some of my billers are telling me that there's something about this mill bill or millennium, something going on, that's a term in the VA space that is very common. Our second term that I thought would be important is the unauthorized claim term. Now, that's not necessarily an unknown term in the claim space for medical care, but in the VA, maybe it means a little bit different than what you might hear from, say, UHC. So again, you can read the definition here in front of you. The good news about unauthorized claims is the VA will approve them to be paid. And as we'll see in some slides that come up later, hopefully the amount of unauthorized claims are on the downward trend. But unauthorized claims, as you see on the screen, for instance, on an ER to inpatient procedure, it may only pay for the to the point of care where the veteran was stabilized, so it may not cover the inpatient side, or ER to outpatient, ER to OBS, whatever it may be. And one of the most interesting things I see in this definition, and I'm not sure if y'all can see my cursor, but it does allow for payment to a person if a person covers the veteran's bill while all this is waiting to be figured out. So if the veteran has a friend that's going to come in and pay their bill, the unauthorized claim process allows for that person to actually be paid back. You don't read that too much in any other payer source. So I'm going to take a second just to take a break from me talking about the screen in front of you to remind everyone, and Lil, you may know if we've got some questions coming in, but hopefully folks are starting to now think about some things with regards to VA claims, and you're starting to ask some questions. I'm going to encourage you to, again, to use the Q&A section. We've got quite a bit of time for this session that we're in. I don't feel like I'm going to run us out of time talking, and I'd love to have more of a dialogue, or as close to we can in this setting at the end of the slide. So don't forget to use the Q&A section. So we've gone over VA coverage. We've gone over some other coverages, Tricare, ChampVA. We've talked about some common terms that you hear in the VA space. And now I think it's important that we've got this background of what's going on with VA claims. We need to back up just a year and a few months in time to June 6, 2019. And why is that day important? It's because on June 6, 2019, the Mission Act went into effect. And I'm sure that everybody on the webinar reads headlines in the paper just like I do. And it depends upon which side of the fence you stand on politically, but you've certainly seen in the headlines that President Trump has done more for veterans in his 4-year term than any other president since whomever. I don't even remember who they were referencing. Well, part of what's gone into that statement by media outlets has to do with what's in front of you now, and that was the Mission Act. And if you wanted to think about, hey, let's just sum the Mission Act up really, really quickly. It basically allows veterans an easier way to seek care within their community without having to go to a government-owned facility. The Mission Act and the concept of what the Mission Act was trying for is not necessarily something new. Before the Mission Act, you had the VCP program, the Veterans Choice Program, and that was the kind of the gateway into where we are now with the Mission Act and the CCN. It started the ball rolling saying, you know what, there are certain criteria that take place in these veterans' lives where their best course of treatment, for a number of reasons, may not be at the VA facility that the government owns. So we got to figure out a way to get them out there in the hands of the people that are best at what they do in the medical field, and that happens within the community. The Mission Act took what started with the VCP program and just kind of beefed it up a little bit. So right after the Mission Act went into effect, everybody who's on the webinar probably started hearing Triwest, 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 Triwest. You used to have two players involved before the Mission Act went into effect, and that was Triwest and HealthNet. And the way it worked was basically Triwest had the left half of the country and HealthNet had the right half of the country. So when the Mission Act, June 6th, happened, Triwest got everybody. And then I'm trying to think back now, within, let's say, 3 months, maybe 4 months of that taking place, you started to just hear little rumblings in the claim space of, well, I think UHC is actually handling that now. And I think CareSource, you started seeing their name involved in this program. And I think if you were to ask me, what's your personal opinion on why that happened? I would say, I think it's because Triwest figured out, whoa, this is a whole lot bigger thing than we might have ever figured. So now when you fast forward to where we are today, over the course of the past year, what happened was the VA started awarding certain regions, particularly 1, 2, and 3, to Optum, and region 4 is Triwest. Now, if you think about what I just said a few moments ago with regards to Triwest and HealthNet, interestingly, the country has almost been split right back down the middle again, and that Triwest now pretty much has all the claims for the CCN network on the left half of the country, and Optum pretty much has the right half of the country. On the second bullet point down, or the second little dash mark down, I've got some stars in there. And I think it's a very important statement. I said it once before on the Tricare slide. Everyone has to be sure that they are recognizing Triwest is something completely different than Tricare West and Tricare East for that matter. But a lot of confusion exists out there between Triwest and Tricare West. Two completely different payers. And as you saw from the Tricare slide, two completely different populations that those, and I'm using air quotes again, insurances are made available to. So that was what the Mission Act did on June 6, 2019. I grabbed a couple of these, I've got them in quotes. They're taken directly from the VA's website. And this is exactly what the VA says the Mission Act is allowing for. And you can see things in there: greater access, healthcare services nationwide, more ways to access healthcare. So as you can see, the Mission Act was just very heavy, maybe on the VA's realization that we can't provide all things at a level that we want to, but also acknowledging the fact that there's only so many government-owned facilities, a VA facility or a CBOC in the country. And when you start talking about, well, how many other private, we'll call them, healthcare options are available to veterans, there's a lot. So that is simply the VA trying to access that really good quality care that all of our members and providers on the webinar are giving out there in the community. On June 6, 2019, if you asked me to stand on a box and hold up a crystal ball and say, what exactly do I see? I would have said, there's no way that hospitals aren't going to see more authorized claims come through their door. And what's interesting to me is when you're talking about providers and you're talking about the VA, that's a really good thing. Now, it's definitely understandable for so many years how providers would roll their eyes at VA claims, and I get it. We work VA claims. We have phone problems on trying to get in touch with someone. We have denied claims. We have submittal of medical records over and over. So I get how it's a problem payer. But with the Mission Act, it took that authorized care up a notch. And just like how you receive authorization from UHC to perform a procedure on a particular patient, you now get that same thing with regards to VA claims. So in my eyes, authorized care at a hospital is good. And if that volume goes up, even better, because you're going to be able to perform a procedure and get paid for it because you've already been told you've got clearance to do it. So that was my first prediction back in June. And so far, that has started and is holding true. And I think it's only going to continue to increase. In the Mission Act, there was a specific urgent care component. And when you talk in layman's terms, and when I'm out talking about my friends about where should you go if you feel like you have a cold, we typically say, oh, well, there is a doc in the box down the street. So I would say that the Mission Act had a doc in the box component to an urgent care. It allows for the veterans to now utilize those independent urgent care facilities that have popped up all over your town. And some of you probably work for providers where you have a few urgent care facilities yourself. But that was a big step for the Mission Act, because before, if there wasn't one of those CBOCs, those community-based outpatient clinics in your area, that veteran was coming to your ER. But now the Mission Act allows them to access that urgent care. So if I'm on my box and I've got my crystal ball, if I'm a hospital, to me, that's good news, because ER utilization goes down. And I haven't been in one single HFMA session all over the country that hasn't talked about, if they've talked about this topic, they have certainly said the ER is the most expensive place to do business, right? So if your utilization of that department goes down for that unauthorized claim that we were talking about before, we're all giving thumbs up. That's what we want. We want the veterans to be able to receive the care they need. But if it's not, using air quotes is so hard on a webinar, if it's not truly emergent, but it be handled in that urgent care setting, that's a good thing. So I think that's great for the hospital. Now, the third bullet point actually happened a little bit after June 6th, but I definitely thought this whole Triwest Optum thing was going to be a rocky road. It has been. And if you read the headlines over the course, basically since, March 11th-ish, whatever date you want to put on that the quote unquote pandemic started, you started getting updates that, well, Triwest is stopping. Oh, wait a second. We're actually not stopping. We're going to continue through September 1st, 2020, and you can continue to submit claims, et cetera, et cetera. And now all of a sudden you had, well, is this claim supposed to go to Triwest? Is it going to Optum? Do I send the medical records to one or the other? Do I send them to the actual VA and they're going to get them to one of those payers? So it has definitely been a rocky road. It is starting to smooth. That is the good news. This is a Georgia HFMA webinar, but we might have some folks from some other regions. But Georgia should be smoothing out in that you should be starting to see more and more Optum-only conversations happening. We're not fully done with Triwest in our region, but it's becoming more and more Optum and less Triwest. So we've been talking about regions, we've been talking about Optum, we've been talking about Triwest. Thought it'd be a good idea to throw this map taken directly from the VA website up on the screen. These are the regions when we talk about who is the TPA for the VA. You can see Georgia, we're squarely in region 3. The only gray area that exists is in that Kentucky, Tennessee, Arkansas, Missouri corner there. You have a little bit of overlap into 2 and 3. So if we've got some region 5 HFMA providers on the webinar, there is a little bit of confusion in that section of those states. But other than that, like I said before, you can see we've kind of come full circle, and that Triwest is pretty much handling left half. Optum is pretty much handling right half. The CCN that came out of the Mission Act amended some of the ways in which you could have access to the community care. Well, what are those qualifications? These are a little summarized, but for the most part, they're taken directly from the VA, in that one of these things has got to happen in order for a veteran to receive the authorization so that they can have treatment at your facility, and then it'll be processed and paid. If you had to summarize what changed the most, I would go to bullet point 4, in that approval for care within the community used to be based on how far you had to travel. There was a shift to move that to how long you had to travel. Small little differences, but if anybody on the webinar happens to live in the Atlanta region, I'm sure you can absolutely understand that driving 40 miles or traveling for an hour or more are on totally different ends of the spectrum, in that there are definitely commutes in Atlanta that are 10 miles that take close to an hour to travel. Now put yourself in the shoes of a veteran that was told, well, if it's not 40 miles or more from the closest VA facility, you're going to have it at the government-owned VA facility. And now all of a sudden you're learning, if your travel time is an hour or more, you can have it in your community. That's a big change. And that's a big change nationwide when you start talking about rural areas, North, South Dakota, Montana, et cetera, et cetera. That to me is the single biggest difference maker that happened in the veterans' ability to seek care within the community. So these qualifications are what the VA mashes itself up against when they get a request to receive care somewhere else. They say, okay, are any of these things going to hold true? And if so, we can approve that care to happen. Bullet points 5 and 6. Well, let's just start with 5. Authorization is in the veteran's best medical interest. That absolutely has always been in the mix. Number 6 started to rear its head a little bit more. And that's where I said earlier, the VA just started to acknowledge, hey, there are definitely providers out there in the community that can do procedure blank way better than we ever could, especially when you start talking about quality with regards to CMS standards, et cetera, et cetera. So the VA is, by this Mission Act going into effect, and now all of a sudden we have the CCN, it's going full bore. The VA is definitely acknowledging we can be great at some things, but we can only be good at others. And if there's somebody else there that provides great care when ours is only good, let's approve them to have it here. Now, what does that translate to for the provider? I think that puts even more emphasis on the quality standards. And we sit in HFMA sessions all the time talking about quality. Well, this starts to affect quality starts to affect this decision matrix. And then when you talk about what I said before, we want that authorized care to go up because you can perform the procedure and be paid for it. It all comes full circle, and that quality is a big metrics a big part of the metrics that can get us more procedures and therefore more reimbursement. There's no doubt that you're going to have VA claims. And I thought we would take 3 slides and we would say, you know what? I got them. I'm going to have them. So what in the world can I do? So we're coming to the part in the webinar where there are 3 things you could take away and you could take back to your team and say, we got to be great at this. And the first one, and I've been talking about this in webinars and presentations for a while now, notification could be one of the best things you could get streamlined in a bulletproof SOP on how your team's going to do it. And it will result in quicker payments to your facility. The VA has a very honest and, for lack of a better term, a really good reason for wanting notification. They want to follow the veteran through the entire continuum of care while that veteran is alive and participating in this network. They don't want to be surprised when the veteran shows up at a government-run facility for things that the veteran's been having, for procedures the veteran's been having done in the community, and then be caught off guard. So their reason for wanting notification is true. Just understand, as I think all of you probably do, notification is absolutely different than authorization. And if your patient access team isn't having conversations on a fairly regular basis about your notification process for the VA, they need to be. And they need to be talking with the business office about what they're seeing, or talking with someone like me as a vendor to the business office of what we're seeing. Because I think, as everybody knows, the patient access goes through the peaks and the valleys of we're really good at this, we're really bad at this, we're really good at this, we're bad at this, we're really good at this, we're bad at this. And for one of our clients, it kind of crept up a few weeks ago, and that we started noticing a little trend. Hey, we just got assigned a claim. We've got no notification on file. Well, they had some turnover within their patient access team. And that just happened to be one of the things that was taught, but not necessarily completely absorbed. And we just gave them a few examples, 8 or 9 examples of, hey, we've got no notification here. They went, hey, let's have a lunch and learn with the patient access team. Let's remind them about this. Problem solved. Now, all of a sudden, we don't see where they're missing any notifications. It's extremely important that that conversation between the business office and the patient access team takes place with regards to notification. The great news, and I have on here new guidelines just came out for centralized notification. I probably should amend that because it didn't just come out anymore. But part of you has to say, well, how in the world are we going to do this? Because, we offer 24/7 treatment. Who's going to do it? Is it third shift? Is it weekend shift? Are we going to catch up for the weekend on Tuesdays? Well, the VA allowed for a centralized notification center, and I've actually put that on here. So the good news is that got easier than it used to be for how you would give notification, essentially at all times of the day. Again, in summary, first thing you could take away if you had to go back to your team and say, what did I learn on my VA call? I think you would have to say notification is extremely important. And it probably comes as no surprise moving to the next slide. What else is important? Authorization. And this just goes hand in hand with the fact that, the Mission Act allowed for treatment within the community. All of that treatment is supposed to be authorized. So you got to get in the habit, just like your other payers, of making sure we've got patient X scheduled for procedure Y on this date. Do we have authorization on file? If not, we got to get it. It used to be that it was the paper fax way of getting an authorization. You'd get something sent to your scheduling fax line, let's say, it had a QR code at the top right. And then if you keep up with any of the VA news, you've seen those letters HSRM come across your screen, the Health Share Referral Manager. That allows your facility to receive these authorizations electronically. And that was a big step for the VA. It obviously, as you can imagine, allows for gains in efficiency. Interestingly, the entire HSRM system went down, somewhere around, I believe it was late July, and it took forever to get it back up. So almost as soon as it got released, it got taken down. It should be back up and running now. I would encourage you to go out to whomever runs that programming or access for your facility, have a conversation with them about, hey, are we signed up for HSRM? If not, let's get us involved. It's a great efficiency gain. When we're talking about authorization, your ER visits don't necessarily have to be authorized, but remember, the VA's got to be notified. So I threw that back in here, even though that's technically notification, but that in essence helps you get what could probably commonly be referred to in the space as, the retro auth. And then when we talk about authorizations, you're receiving those from, different payer sources. Right now, especially in our region for Georgia HFMA, you should be set up for EDI transmission for 3 payers still. The VA, the traditional VA, Triwest, and Optum. It is not safe to just replace your Triwest EDI transmission with Optum and say, oh, good, we're done. Triwest said they're through. Because there are still unpaid Triwest claims, I'm sure from, 6-8 months ago, where you might be working them. And they might say, well, something happened, please resubmit the claim. You're going to want to do that electronically. So right now, you can't just whittle yourself down to 2 EDI transmissions. You still need to have 3. And that's what answers that question that I have in the parentheses at the very end. But Triwest went away. It did, but you still got some billing that might take place for unpaid claims. All right, so you got VA claims. The last little thing, what should I do? Very, very important. Make sure you're capturing primary payer information at registration. And it's safe to slip in there, maybe make sure you're capturing secondary payer information, because depending upon the conversation with the person is having with your patient access team, they may feel, well, no, VA is my primary. And for all we know, they may be correct. But I would implore you to have, the question that I've typed out on the screen or the statement, approved by whomever needs to do it at your facility to say, just in case the VA doesn't pay, is there another payer you'd like for me to have on file? If the veteran has Medicare, or if the veteran has a BCBS, plan of some sort, very important to get that at time of registration, because as the VA claim transmits and then we work through time on working the claim, you're going to want to know, hey, do I need to shift gears on this and send it out to a different payer? The last bullet point, just something to consider. When your business office is working VA claims internally, are they in the habit of checking back to, visits that may be 3 to 6 months old to see if there was a payer that was available that all of a sudden didn't get pulled forward? I would always think that is some ongoing training for the 1-day-old employee or the 100-day-old employee or the 2-year-old employee. They could always remind themselves to get back in the habit of going and looking for, was there another payer source available on a previous claim? Now, we're going to shift gears for the last time, I believe. Let me look through. Yep. Last time, we're just going to go over 2 case studies. I thought it might be important just to see some of, some things that are happening out there in the real world. I will hurry through these. I'm going to admit that they could be interpreted as a touch salesy. I've tried not to make them that way, but I want the audience to see, if you put a concerted effort around VA claims and you consider them extremely important, even though they're only making up a small percentage of your total patient population, what sort of results could we get from VA claims? Our first case study, 83-bed hospital. They see about 91,000 patients a year. They actually have an average charge of $8,400. So for an 83-bed hospital, that's really good. They had 1 FTE working VA claims, and they only had 102 VA claims a year. So really, really, really small amount of VA claims. The problem is, and you can read this in the second bullet point, 46 of those were basically being determined, we can't do anything to get paid. 26 were going to self-pay, 20 were just being written off completely. So they decided we got a solution. We need to get a solution. We got to outsource the VA claims, and that employee that's spinning their wheels on the problem accounts, they got to shift over to Medicare Advantage. And the reason this hospital thought it was important was because Medicare makes up just over 40% of their patient population. So, just real quickly, back of the napkin math, they could probably use as many people as possible dedicated to a payer source that's 40+% of the population. So they outsourced. What happened in the first 2 years they outsourced in 2018, 2019? It went from 26 claims to 1 claim moving to self-pay, and 20 claims to 0 being written off completely. So for the VA, man, what a success story, right? Those claims are getting paid. We're not having to spin our wheels. But then what's the real net effect maybe of this? The stuff that Argos couldn't see. Remember, they wanted to shift that person over to Medicare and Medicare Advantage because it makes up so much of the population. Medicare Advantage AR decreased 50%. Aged accounts over 180 days, and the Medicare Advantage went down 90%. Huge efficiency gains once those VA claims started being worked correctly. Last case study, hospital system, 714 beds, 2 main facilities, some ancillary facilities. Argos went to work in January 2020. So far through maybe yesterday even, if not the end of last week, $2.736 million more than the year before when they were working internally. That's a big chunk of money. That all comes about because of sole focus, horsepower, general knowledge of what's going on with VA claims and how to react. I will summarize with this before and after page, and I'm just going to leave this one up here for just a second. Lil, I think we can start answering questions now.
Okay, sounds good. You got quite a few, so.
That's a good thing.
Yeah, so Carl Guyton, we're experiencing provider load issues with Optum. Who can we contact to get these matters corrected? Who is the provider rep?
Yeah, I think UHC is going to have to answer that for you. And you might be shaking your head right now saying, I've tried them. That's the only route that I know to go. Full disclosure, we don't get heavily involved on the contracting side of us because hospitals, providers have someone that does that way better than we do. We don't claim to be a contracting rep, but I would think your UHC rep will start to point you in the right direction. And Lil, if I can be emailed that, I'll take a little bit of time after this and I'll go to the Optum CCN provider manual and I'll just see if I see something real quick. I'm not going to search for it while we're on the webinar, but if I can just know who to contact later, I'll send them what I find in that provider manual that Optum put out.
Okay. Or Carl, they can email you directly with the question.
There you go.
Perhaps that might be a better way.
Sorry, Lil. Yeah, even better. I just changed screens. So there's my email address. If you'll shoot me that, I will respond with what I find after I do a little digging.
Okay, great. Next question, Jessica Francis. Can a provider call and request authorization for an emergency room visit, or does it have to be the patient that calls?
Yes, you can seek that, what I'd call it the retro auth, and you're going to do that. You're going to start with notification that you have a veteran in-house, we'll call it, through the ER. And then you can shift that over to receive an authorization so that when you transmit the claim, that will be included. But you're going to start with this part of the screen right here, either that the email, or in those situations, you're probably going to be best to call because you're going to want to then have the conversation of, we want to get an authorization for this as well.
Jessica had another question. If a VA patient presents for a COVID-19 screening test, is it up to the member or the provider to try to obtain the authorization?
Oof. Jessica, that's my email. Will you email me that question? I do not know that COVID specific answer.
Okay.
And you know what? Sorry, Lil.
Yeah.
I hope the VA knows that answer, but I'll search for what I can find. Jessica, if you'll just email me directly.
Amberly, if something is unauthorized, do we just send the claim to the VA, or should we go about getting the VA to process the claim?
I think I understand that correctly. Yeah, your unauthorized claims are still going to go to the VA for now. There is language you can see out on the va.gov website that says those will start to go to Optum. At this moment in time, I haven't seen anything that says that has definitively started. It makes a lot of sense that those are eventually going to go one route, but yeah, that's why you need those 3 EDI transmissions. And just go ahead and prepare yourself when you're going to go to follow up on those claims. If you're not using the VA's online tool to check claim status, you're going to get into a phone tree that's going to be painful.
Okay. Jessica had another question. When a patient presents to the facility or treatment service, how will the provider know whether to send the claim to Triwest or versus the VA?
You'll have that authorization. You'll know if it's Triwest or Optum because it should have gone through scheduling, et cetera. So, when the patient presents on October 20th for treatment, whatever systems you're using to schedule and then capture that information should already be waiting on you for the patient's procedure, and you'll know that's going to go out the door to either the Triwest or the Optum route.
Okay, Carl had another question. Have Triwest members in Region 3 been transitioned to Optum yet?
Yes. It would be a very, very rare instance where a new claim in Region 3 would go out the door to Optum. But Carl and everyone else, I would still ask the question, have you contracted with Optum in order to receive that authorized care and thus send the bill to Optum. There are still plenty of hospitals out there that have not signed up to be part of the CCN network. And when I say that, think about this. There are definitely providers where only a portion of their facility has signed up. So maybe the hospital has signed up, but the organization also runs a hospice program or a home health care program. So have you signed up everyone to be part of Optum, or are those all blanket signed up under one umbrella, or do they have their own NPIs and thus their own contracting, et cetera? So there are definitely some potential holes in the armor that will need to be patched to make sure all of your, let's just say, NPIs could actually bill to the Optum payer. But yeah, anything you receive now for a new authorization should be all Optum. Now, whether or not the veteran knows that, that's a whole nother story.
Okay, Kim Howard had a question. If there is a problem with an authorization that you need corrected, the local VA states cannot do anything with authorizations after June 8th, 20. The national line cannot do anything on dates of service prior to October 2019. What is the solution?
Either Triwest or Optum. Yeah, that's not necessarily a VA thing at that point. That would be a TPA thing. And again, feel free to email me if you've been told different, but to your first step in that is not the VA, it is towards Triwest or Optum to get that clarified. Because, and I guess, gosh, every answer with a VA gets gets complicated quickly. There is absolutely the potential, and I'm not clinical in nature, so forgive some of my stupidity in trying to describe this, but the VA may authorize Kirby Yawn to have a knee surgery. The VA doesn't authorize Kirby Yawn to have a knee surgery, and while that's happening, something else comes up and it's just lumped in and it's paid along with the knee surgery payment. So I don't know on that specific question if you're dealing with, are they denying, or are they saying they're not going to change the authorization for that specific procedure, or do we need to look closer at the claim to say, oh, it's actually got another part in there that needs to be retro authorized because X came up while procedure taking place. It gets complicated quickly.
Okay, Latanya Temple had a question about, can an ER provider call for authorization? We're not working at the hospital.
Can an ER provider? Can you email me that question? Lil, who asked that?
This is Latanya Temple.
Latanya, can you email that to me? I may just need to get a better idea of what your facility is, just to make sure I'm answering that correctly.
And we have Jessica Francis again asking, Arkansas provider, local VA has told us that provider cannot notify them of a patient visit. Has to be the patient that calls and notifies of the visit service. However, you're stating that as we are providers, we should be able to start this process.
Absolutely. Jessica, we may need to have a conversation offline, and I can point you to some spots directly from the VA's website. I'm not sure why you're being told that for that visit, all of a sudden the patient's got to pick up the phone. I mean, if you think about it, to me, that doesn't make sense because, I mean, what if that visit goes ER inpatient for 3 days or ER OBS for a week? I don't think you can rely on the patient who could be incapacitated at that point in time to notify. So that's interesting, but you and I may need to have a separate conversation about that.
Let me see how many more questions we have and how much more time. It looks like there's a handful of questions still. I think we can go for another maybe 5-10 minutes, but then I have to prepare for the next session.
Sure.
So we'll do one more here, or a couple more. We'll give it five more minutes.
Sure.
And then I'll send you these questions, and then maybe you can respond to them. Or if your question has not been answered, then just, you don't mind, Kirby, if they email you directly?
Perfectly fine.
Okay. So new VA biller regarding the regions map, is that showing the change from where Optum took over more states? I am I guess Indiana maybe, provider and have claims for members for Triwest and Optum. Also, what about the VHA Office of Community Care? I have multiple letters that have been received by Optum for claims mailed to Triwest, advising the claim to be mailed to VMU PO Box 30780 Tampa, Florida.
Yeah, that's
Dr. Smith.
I'm probably going to have to, I don't even know if I can remember all that, but yeah, this screen in front of you is where the VA awarded those contracts. And just for instance, there was some litigation on whether or not Washington, Oregon, that area was actually going to go with Triwest, and then it was determined they would. So yes, this screen is current. And my assumption on what you're seeing in Indiana is you're in that rocky road of Triwest to Optum, so it gets confusing. And if think about this, let's just say in June, the VA authorized oncology care for a patient, and that was done through Triwest. And for the oncology, I don't know, they were going to have to receive, an injection a week for the next 6 months. Well, now we come to the point where Triwest said, I'm done, and Optum's taken over. So you've got authorized care through Triwest, but all of a sudden they're not going to be the TPA. It's not as though you can really stop the oncology treatment because we're trying to cure that person and treat them for cancer. So you've got some major confusion on, well, when's that cutoff happen? Where's that bill go? How'd that get authorized? How'd that get converted over to Optum? And for lack of a better term, those are competing companies. So they didn't necessarily develop their own software to talk. So yeah, a heck of a situation there that's probably going on in Indiana. And I don't even remember, Lil, now what really the second and third part of that was, but I know it had with where to send your claims. I'm happy to take a look at that further on an individual email.
Okay, Latanya Temple asked, do we need to bill VA first so that Optum can obtain medical records?
Not bill, no, your bill, if you've got authorized care from Optum, your bill goes to Optum. It was announced that your MedRecs would go to the VA and the VA would make sure they got to Optum. That is definitely still murky water. One, is it happening at all? Is it happening most of the time? Should you really just be sending that to Optum to go ahead and cut down on the procedural nightmare? That has not become a bulletproof process yet. But if you've got authorized care from Optum, you should be billing that EDI out there to Optum.
Okay, we have time for one more. Jackie Hooley, is there a reason that we are contracted with VA Optum? We are still getting Triwest authorizations, and those authorizations look like VA Optum auth. Oh my goodness, that's a big one. Did you understand that, Kirby? So they contract with VA Optum, but they're still getting Triwest authorization. And those authorizations look like VA Optum.
I don't know what you're looking. I don't know if I can answer that one without. We might could share a little bit of info afterwards, maybe some screenshots or just some samples. Depending upon where that hospital is, you should be converted over to receiving authorization from Optum in that CCN network. Hopefully you've got your contract on file with them. That may be retro. Just had a conversation today with a hospital. They absolutely know that they received their Optum contract approval, signing off on it, et cetera, and it made it retro to June. However, you can't forget Triwest agreed to stay in the game till September. So that's where you've got some possible confusion there, but that's a very hospital specific situation. It sounds like that's going on.
Okay, well, Kirby, thank you so much for your time. You have given so much information that I know that the participants find it valuable. I'm very generous with your information. Thank you. And attendees, please join us for the next session that starts at 2:30. And it is about transparency. So I'm sure you'll get a lot of valuable information from the next speaker. Thank you again for joining us. Stay safe and have a great afternoon. Thank you.
Well,